Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. I hope everyone is having a good February so far. I also wanted to say an early happy Valentine's Day to those who celebrate. I got some roses from my husband last week, so he doesn't like to give them to me on Valentine's Day because he says he loves me every day of the year. So after almost 25 years of marriage, that's probably a good thing. Also, shout out today to my daughter Summer. It's her birthday. Yes, she was almost a Valentine's Day baby. So love you, honey. Hope you have a great day. Can't believe she's 29. Boy, how old does that make me? Old. That's all I'm going to say. Yes, I'm over 50. Boy, I better be. Otherwise, I had her very young. Anyway, today's topic is something that actually I've been reading about, and I just thought it was a really good place to start today because there's still a lot of confusion with the 2021, 2022, 2023, and now we're in 2024 E&M guidelines. And so one of the things that we always talk about is, or I should say are the data points, but I don't want to go there. I want to talk about the number and complexity of problems addressed because it seems like the majority of E&M services billed are level 4s. And I get a lot of physicians emailing me. I actually even had a couple of practices last week saying, can you give me examples of level 5s? My doctor just wants to know those. And I'm thinking, no. I can, do an education piece to show you the difference between all the levels, but I'm not just going to give you a bunch of level 5s so now your doctor can go and template at that and say, this is what all of our visits are going to look like. Be careful with that. When you have a provider or a physician saying, I just want to know how to get to a level 5, that should be a red flag for you. The hair should stand up on the back of your neck and you should be like, yeah, I'm not doing that. That would not be a good idea. So let's just take a look at problems addressed because I want to make sure that if you're looking at those, one or more chronic illnesses with a potential exacerbation, progression, or side effect of treatment, or 2 or more stable chronic illnesses, versus going straight to a level 5 saying that this was a chronic illness with severe exacerbation, and that word severe is pretty important, or if you're saying that it's an acute or chronic illness that poses a threat to life, you want to make sure that you can support that in the record. And I just want to explain at least the understanding of what chronic illnesses are. And I want to actually take a page also from a good friend of mine, Betty Hovey's book. She did a blog on the NAMAS site, which I'm going to reference a little bit and then add my own information into there because I thought her wording was really good. But first, the Codecast podcast is also brought to you today by the Netflix series, The Lincoln Lawyer. Check out seasons 1 and 2 on Netflix.com and look for season 3 to drop fall of 2024. The Lincoln Lawyer is based on Michael Connelly's book, The Gods of Guilt. The 3rd season of The Lincoln Lawyer will have 10 episodes. I can't say I'm not excited about that. One of my favorite shows. Has any of you seen the Netflix Suits? Oh my gosh, don't even get me started. I'm already watching it for the 3rd time. And actually, it's now just noise in my home office when I'm working. But if you haven't watched Suits, 8 seasons on Netflix, and then the last season is on Prime. So just try it. You'll love it. And the beginning music, I love it. Anyway, that's an obsession with me right now. Okay, let's get back to the topic at hand and talk about when we're dealing with these E&M services and really looking at chronic conditions or exacerbated conditions. But I noticed that a lot of physicians and the qualified healthcare professionals, so the QHPs, they sometimes will credit the chronic exacerbated condition instead of just a chronic stable condition, but they have to make sure that their documentation can support if you're saying exacerbated. So stable chronic condition is pretty straightforward. That means it's managed, stable, predictable. Let's say you have hypertension or diabetes, there's no changes. You have a patient, let's say, for example, with well-managed hypertension whose blood pressure readings and symptoms are under control, that maybe they're also medicine controlled, where they're on lisinopril or they're on some medication. That would be considered a chronic stable condition. And you also want to make sure that you have treatment goals or what the provider that's following the patient says that, their blood pressure needs to be at. Same with, let's say, diabetes. So there's treatment goals for that as well. Let's say the patient is on metformin. Let's say they're type 1 or let's say they're type 2 diabetes, because they can be controlled with medication or insulin or diet and exercise. So type 2 is actually what they call, and I'm air quoting the better diabetes. Type 1 is tough because you are insulin dependent. But let's just say they're having consistent glucose readings at home. They're within a commonly acceptable range. Plus, they also have had their blood work and their A1C is still showing, somewhere around, let's say 6 to 8. But based on the patient's condition and lifestyle, and based on what they've had a conversation that's well documented with their provider, it's supposed to be down to under 6. And they have not been able to get that down further. Maybe they aren't sticking to their diet as well as they have said they are. And there are some conversations like that the doctor really needs to address within the medical record. That could be considered unstable or exacerbated. Because remember, when you're looking at the new guidelines and they talk about treatment goals, and even though a patient might be living with a chronic condition that's controlled, if they're falling short of their treatment goals, that's not considered stable as far as the AMA is concerned in their documentation. And so it really emphasizes, and I agree with Betty on this, and that she's referenced, that every patient has a unique set of goals and circumstances. And achieving these personalized objectives will determine the stability of that patient in reference to how you choose that beginning element of the level of service. So was it a one or more chronic illness with exacerbation, or was it really a stable chronic illness? And, it's really, again, tied to not only that treatment goal, but also if you're an auditor like I am too, and you're trying to figure out in the record what's going on with that patient, here's some things you want to look for in that record. So first you want to, and I'm also speaking to the providers out there to include this in the record, treatment goals outlined for the patients. The chronic conditions are evident and well documented. It could come into question where, let's say a patient, has, I always reference the diabetes because this is really easy to find in the record. But if it's not at goal, or if there's no goal mentioned in the record, you may need to query the physician, because now what is that? Or is that just considered, one stable chronic illness, and now you're in the low addressed problem category? You're not even up in the, if you have 2 or more, in the moderate. And then what about, are these goals evaluated and updated continuously? Aligning with the patient's progress and condition. And this is important too, because maybe they're standing orders for, every 3 months the patient gets their labs just to check in and see where they're at with that. Instability is a condition that may be classified not just considering the severity or changes in the condition, but again, also related to the patient-specific treatment goals. And that's really the key. If you can get your providers to really add that layer of information and documentation to the record, that can help expand that definition of what really stability stands for when it's related to chronic conditions. And it can help not only the auditor, but it can help the provider to report the code that's really accurate. I mean, it's inaccurate if the documentation isn't there, first of all, and unfortunately the auditor or the person coding for the provider, if they're not coding, they're having to default to the lower code because they just don't have enough information. So just remember that when we are in 2024, everything is around patient-centered care, and it's specific for that patient. And that's probably the thing I'm trying to get physicians to understand, because I see all the time, especially when it comes to decisions regarding minor surgery or major surgery with or without risk factors. Well, I see the physicians putting in their generic statement about the risk factor for the surgery. Well, all surgeries, I should say, have risk factors, especially if you're going under the knife or you're going under anesthesia. But this particular patient, what is their risk factor? Perfect example. A friend of mine, his mom just went under a double mastectomy, and we wish her well. But unfortunately, she was supposed to have her updated reconstruction and tissue surgery and implantation, but she couldn't because she started having palpitations, and then they found that she was an AFib, so now they're deciding if they want to do some Eliquis and do some medical management before they, again, start another surgery. Well, the risk to that patient is not just the surgery risk, but it's the anesthesia risk and her undergoing the procedure at all based on her medical makeup or her medical complexity. And that needs to be documented, not just the fact that reconstructive surgery and somebody going under, anesthesia is a risk. How is it a risk for this patient? What does their medical, condition, their risk of complications and or morbidity and mortality, again, for this patient, based on what the management or the treatment options are, what is that? And it has to be individual. We can't just make that lateral assumption anymore. Diabetic patients, for example, take longer to heal. So you could assume that if a patient's going to have, let's say, with shoulder surgery, they're going to have a longer time healing, but not necessarily anymore. You could, if you were a clinician, I'll say, because everybody knows that I used to be, I say I used to be a nurse because I'm not a practicing RN anymore, but I keep it up. But I'm not practicing anymore, so let's get that straight. But the one thing that you have to keep in mind is that we are not allowed to, as auditors, make that leap. The physician has to document the complexity of that patient and the risk. And the risk for the actual diagnosis is different than the risk of complications based on what you're going to do with the patient and the morbidity and mortality. So know that there is a difference. It's not the risk of the diagnosis. It's the risk on how it's going to affect the patient in your management or treatment of that patient. And so it's so important to take that patient as an individual. So make sure that you're doing that. If you're an auditor looking at E&M services, make sure you're talking to your providers about that, because that's what's going to support their level 3, 4s, and 5 services. Obviously level 2s, those are minimal self-limiting problems, minor problems, and really no risk of morbidity or additional diagnostic testing or treatment. So we don't really follow that with level 2s, but anything above a level 2, you have to be able to identify not only the risk, but relate it and show your thought processes to that individual patient. Otherwise, it's very hard, not just on the auditor, but also on the payer to figure out what are you trying to say. And a lot of times that lack of documentation or the perspective of the physician is just not there. And we can't make that leap on our own, because if we do, we definitely would get in trouble for that, because now we're making assumptive inquiries, or I should say assumptive notations based on, well, that's what the doctor meant to do. We can't do that. Or that's what the provider meant to do. So try not to do that. Make sure you're educating your physician and talking to them about make it individual. And that's what's going to make a difference in supporting your information. So I hope that was helpful today. I know sometimes you just kind of have to hear it and think, oh, okay, now I can kind of bring this to my physician's attention and really talk to them about how to make it about the patient and not about the documentation. And definitely don't make it about the coding. The coding will take care of itself as long as the documentation is supportive of what you're doing. So when you hear this, the Super Bowl will be over. I don't know who you're picking, but I'm so sick of the Swiftie stuff. So I might get cards and letters for that, but I'm sick of it. She's not my favorite person. I go in a different direction when it comes to music. So for me, my husband doesn't want the 49ers to win because we don't want the Steelers to, we don't want anybody but the Steelers and apparently the Patriots to get more than 6 Super Bowls. And the 49ers have 5. If they win, they get 6. But I like the Brock Purdy story. So I'm kind of over the whole Mahomes-Kelsey thing. So we'll see what happens. I know some of you may not agree, but when the AFC is when we are out as Steelers, okay, who in the NFC is going to take the trophy? So I think I am a 49er fan this weekend. So we'll see what happens. All right, everyone. I will talk to you next week, and I'll let you know if I actually made the right bet. Have a great day. Have a great rest of your week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.